hello and welcome. What a pleasure it is to greet you all to this third and final iCMLf hosted key discussions on CML, the South Asia series. As you get settled in, I'll take a moment to let you know a little bit about the International CML Foundation's work, if I may. So I'm Arlene and I run the Foundation's clinical programs. We are a physician and researcher-based foundation, and we have two key priorities, both of them working towards improved outcomes for CML patients around the world. Firstly, we are raising the bar of CML management through CML education, and that includes meetings just like this. And over the last 13 years, the Foundation has been working via preceptorships, meetings, symposia, and online, for example, with the Knowledge Center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the very best possible knowledge, opinions, and experience. And in case you aren't already aware, some of our international experts will be going to Mumbai for the India Cancer Congress, and we're hosting 3 separate meetings there on November the 3rd. So if you are attending the India Cancer Congress, or if you're based in Mumbai, please let us know, as we'd love to meet you there. The other side of our work is harnessing the power of global research. Our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance, we did a lot of work around CML and COVID, we have a hepatitis B survey in preparation, and we're looking at pregnancy in low and middle income countries, pediatric treatment of CML in low and middle income countries, and much more to come. So that's a brief overview of the International CML Foundation, who we are and what we do. So let's get on to our 2 topics for discussion today. Those being key issues in treating children and young people with CML and the impact of CML on pregnancy and fertility. Okay, so key issues in treating CML in children and young people. It's a great pleasure to introduce our first international expert for today, Professor Meinolf Suttorp from Dresden in Germany. Professor Suttorp is a senior professor in pediatric hematology and oncology and a global expert in pediatric CML. He has been a great friend to the International CML Foundation over the years. I believe he's trying very hard to retire after many years of dedication and excellence, but everyone else in the world with an interest in pediatric CML is determined to keep him on board. Meinolf, thank you so much for joining us today. We're very honored to have you here. Our regional expert is Professor Nirmalya Roy Moulik. Nirmalya has a huge amount of experience in treating children and young people with CML here in India, and he and Professor Suttorp have co-chaired the iCMLf Knowledge Center module on pediatric CML. More on that to come later. Welcome, Nirmalya. It is a real privilege having you here.
Thanks, Arlene. So we'll give a brief introduction to pediatric CML. Pediatric CML is the rarest pediatric cancer in children, leading to due to rarity of this condition, the data is also very limited. However, data from the low middle income countries are even scantier, in view of only a few handful of studies with limited number of patients from the developing countries. And the guidelines that are formulated in the Western world are used in the developing countries as well, in want of proper setting adapted guideline. But then these guidelines always don't suit the purpose of managing children back in this part of the world because of certain reasons that we'll explore in the next few slides. So in our experience, and also based on a survey that was done amongst various physicians treating children with CML across the low middle income countries, we have arrived at various issues that they face by managing children with CML. And then these problems are multifaceted. Starting from the problems that are seen from the patient side, we see delayed presentation and delayed diagnosis in such patients. Our patients are more often likely to present with higher and with advanced phases as compared to that reported in the West. We have issues of compliance to treatment. We have issues with follow-up and monitoring during ongoing treatment. And of course, treatment and investigations lead to a lot of financial toxicity and to be encountered by these families and children, leading to further lack of compliance. From the physician's end, there is not adequate training or expertise among the pediatric hematologists or pediatric oncologists who should ideally manage pediatric CML, leading to the non-pediatric hematologists to take over the care in many of the situations. Even in our country, many children with CML are treated by adult hematologists. And of course, the physicians or the pediatric hematologists don't get a ready reference to setting appropriate guideline to follow in our country, or I mean, for that matter, for any other LMIC countries. Regarding treatment and investigations, there is a huge gap in the lack of facilities and in the form of diagnostics as well as monitoring during treatment. In various low middle income countries, some are slightly better off, some are not as good, including lack of fish, lack of regular RQ-PCR monitoring that we have seen in the survey that have been highlighted by many of the respondents. Not only regarding diagnostics and treatment-related monitoring, we have seen that steady availability of tyrosine kinase inhibitors is also a big problem. And also we have a huge issue with the cost of innovator brands, especially the cost of second or third generation TKIs. And also some of the countries do have their generic industries producing a lot of, these low cost medicines, but their quality and quality control is also questionable. These children, children also suffer from limited options between having many other TKIs as compared to the West, because of course, lack of support from the government or from the health system. And of course, because many patients present with advanced phases of CML, it's difficult to manage such advanced phases in our setup because of insufficient resources, as advanced disease demands more intensive treatment and transplants as well. Coming to the last point, that was raised during our exploration of the problems. During follow-up, compliance to appointments have been a problem. I think it's a problem across the world, but it's more prevalent in the low middle income countries. Adherence to monitoring schedule as prescribed by the Western guidelines is also a big problem due to cost and of course availability at times. Children with TKIs, they encounter a lot of off-target toxicities, as we all know, and monitoring of such late toxicities and timely referral and timely treatment of such toxicities is of paramount importance to improve the outcomes, which also don't happen as smoothly in the LMIC countries because of obvious reasons of difficulty in cross referrals, getting adequate investigations in a timely fashion. And of course, when it comes to transitioning their care to adulthood, it becomes a huge task, because many of these children generally refuse to move away from pediatric practice to adult practice. And of course, there should be an adequate setup to do that, which is also lacking in most of the cases. So just to summarize, the key issues that we have seen in managing such children is the diagnostic delay, and of course, delay in presentation as well, which is included in it as well. And of course, when patients come with acute complications like organ damage due to high white cell count or something of that sort, outcomes are often dismal because treatment is initiated quite late. Management of advanced phases is, of course, very difficult in our setting because of lack of second generation or onwards TKIs, and transplant is sparingly available for the masses. Coming to management of chronic phase is so easily managed in the West, but compliance to treatment and access to medicines as well as investigations remain a huge problem in our setup. And finally, as we have discussed, follow-up remains a problem due to lack of proper multidisciplinary care. And of course, the other reasons actually contribute to issues with follow-up as well. I think this is a summary of the issues that we face while managing children with CML in our setting. I have 3 cases lined up, one after another, which would actually highlight the problems that we have just discussed. So I'll very briefly go through the 3 cases, and after each case, we have some questions for Professor Suttorp, who happens to be a very experienced pediatric CML physicians and have been guiding us for the last many decades now. So the first case from our practice was a 14-year-old boy who presented with a sort of longish history of about a month with fever on and off, as well as some abdominal distension with left upper quadrant dragging sensation. However, 4 days prior to presenting to a hospital, this child developed continuous painful penile erection, and 2 days into it, he also developed decreased vision on the left eye. His outside investigations showed a borderline low hemoglobin, very high white cell count, and a high platelet count as well. Differential blood cell count, was overall okay, but peripheral smear did show 6% of blasts and high basophil percentage as well. A bone marrow was also done outside, which just mirrored the peripheral blood smear, showing 7% blasts and 3% basophils. Fish done from outside showed 98% cells having translocation 922. In our hospital, these investigations were all repeated, and most of them went hand in hand with the outside investigations: low hemoglobin, very high white cell count, high platelet count, differential counts showing a left shift, as well as excess of basophils and eosinophils in this patient. Cytogenetics also showed 98% of translocation 922. RT-PCR done in a hospital showed BCR-ABL transcript with P210 transcript type. Bone marrow morphology showed 1% of blasts, and flow cytometry didn't show any abnormal blasts at all in this patient. A kinase domain mutation was requested, which detected no variants. So coming to treatment quickly, because of this high white cell count and end organ damage, we started him on low dose cytarabine, 100 milligrams per meter square for 4 days. Hydroxyurea was also started. Imatinib was also started because of the outside report of fish positivity. The priapism was dealt initially with a wide-bore needle aspiration. However, due to persistence, on the next day, he underwent a distal shunt surgery. The left eye painless loss of vision was evaluated and was found to have vitreous hemorrhage. No acute intervention was advised by the ophthalmologist. He eventually developed secondary glaucoma on that side, which needed topical anti-glaucoma measures. Following this, due to the medical management that was instituted, the counts slowly came down. By day 10, we were able to start tapering hydroxyurea, and imatinib was continued. Giving a quick follow-up of this patient, now it's been more than 1.5 years since the time he started his treatment with us. And currently, this child remains in major molecular remission, which was attained at around a year from the time of start of treatment. This child is otherwise doing well. He has good compliance to imatinib. However, he lost his vision on the left side, and he has total loss of erectile function due to the priapism that was dealt with in a delayed way. That became irreversible due to delayed treatment. So, this was in a nutshell the case that I wanted to present before you. And our questions for Dr. Suttorp are this hyperleukocytosis, which is not uncommonly seen in our patients. How best to manage this? Whether medical management is only fine, or early institution of leukapheresis in addition to medical management would have changed the outcome in this child.
Yes, thank you, Nirmalya, for preparing this case, and thank you, Aline and the iCMLf for organizing this meeting. Hello to everybody. This case has some aspects of leukostasis. As Nirmalya pointed out, in pediatric CML, the high white cell count is rather common. The median white cell count is around 250,000 per microliter, which is different from adults. But leukostasis, especially priapism, is a rare event. In a Japanese analysis, 1.5% of all boys presented with priapism. And in our own cohort in European register, there were 3%. So that is really a rare situation. And in CML, we must well separate hyperleukocytosis from leukostasis. Hyperleukocytosis is defined by 100,000 cells per microliter, but signs of leukostasis are really rare in CML. And the loss of the vision of the left eye might be due to the bleeding, the vitreous hemorrhage, maybe that there is even occlusion of the retinal vein. And the priapism, if not treated immediately, will result in loss of erectile function. This is an emergency scenario, and you have to treat the priapism first by all means, not only aspiration of blood, but also injection of suprarenine. But if it persists longer than 48 hours, the scenario seems to be hopeless. So about the management of hyperleukocytosis, medical only, I would say if there is such an emergency scenario, you have to do something more. There may be leukapheresis, if this is possible at the treating hospital, or exchange transfusion, especially in younger children. Exchange transfusion does not require so many units of red blood and is associated with less complications. Medical treatment only requires time. As in the case you described, TKI alone will halve the white cell count within 2 weeks. And combination with hydroxyurea and low-dose RRC might achieve 30 to 50% reduction within 3 days. So this is something you, I think you must do if there is a sign of leukostasis, which does not only affect the penis and the eye, but also the lung and the brain, and this really is an emergency situation. Okay, the role of aspirin, not at all is my recommendation, because the high thrombocytes bind the von Willebrand factor, and 60 to 70% of children have low von Willebrand multimeres. So they have a tendency to tooth bleeding, to bruising, and the aspirin might worsen this situation. There is really no role for that drug, although the platelets may be as high as 1 million. About the staging of this boy, although he presented with this severe organ damage, it is a classical chronic pediatric chronic phase of pediatric CML. And the response you demonstrated with imatinib was excellent. There was, if I remember correctly, at month 10, 0.02%. So this is almost an optimal response by month 10 already. a deep molecular response, sorry. It was an optimal response by month 3. And so there is no need to use the second generation TKIs upfront. Imatinib works fine. But most important is the regular monitoring to follow this response and to do everything that the teenagers and the younger children with their parents adhere to the treatment, that they take the drug daily, that they have the 3-month PCR done for monitoring so that you may detect these rare cases of failure. That brings us to the follow-up strategy, whether peripheral blood or bone marrow should be used. I think this is a clear answer that peripheral blood is as good as a bone marrow. Once the cytogenetic response has been achieved, a complete cytogenetic response, no Philadelphia chromosome detectable, then you do not need bone marrow any longer, and you can proceed with the reverse quantitative PCR to monitor the BCR-ABL1 rearrangement. And luckily, after 3 to 4 years of treatment, there might even be a stopping attempt justified if the deep molecular response is maintained.
Right. I have a quick question here, Dr. Suttorp. So what is your comment on peripheral blood cytogenetic response? I mean, do you ever do that, or in case you have to do peripheral blood, you should do only molecular?
No. Peripheral blood FISH technique should only be applied if you cannot do a bone marrow. Because in the peripheral blood, when the hematological response is achieved, you will see some 50% of granulocytes, and you see the lymphocytes, and the lymphocytes with a good response may be negative by FISH technique, so they will dilute the cytogenetic results. Cytogenetics from bone marrow only.
Right. And molecular tests are almost 3 times costlier than cytogenetic tests in our country. So, I mean, as a strategy, what we do in our hospital is till the time patients attain CCYR, complete cytogenetic response, we don't do molecular. Only when they clear their cytogenetics, we start doing molecular. Is that a sound approach? I mean, what is your thought on this?
Well, if you compare the sensitivity of cytogenetics to PCR monitoring, the PCR of 1% or MR2 is equivalent to 1% of Philadelphia positive chromosomes. So when the cytogenetic monitoring becomes negative, you'll be in the range of 1 to 5% by PCR results. So if you have limited resources, this is a reasonable approach.
Great. Thank you.
I might step in and say that Dr. Meinolf has asked a question using the chat function. He says, thank you for wonderful discussion. My question is, broken TKI is as effective as the total one? Dr. Islam, you may want to follow up with and explain that a little bit more, or Professor Moulik, Professor Suttorp, you happy to take it as it is?
What is meant by broken TKI?
I think breaking tablets versus following the whole tablet.
Oh, I see. Well, yes, the problem is that the smallest tablet contains 100 milligrams of TKI. So there is no other chance than to halve the tablets. And over a period of a week, you may have 60%, and then the next day 40%, but roughly it will be a 50 milligram dose what you apply, and that works. There is a broad therapeutic range with TKIs, and with the lowest increment you can get in small children. There might be a high dose, but the high dose works better if it is tolerated from the viewpoint of side effects. This is okay. But what you should not do is to interrupt the treatment. Give 100 milligram tablet one day and nothing the next day, and then 100 milligrams again. That will result in poor plasma levels and in high toxicity in small children.
Yes, and crushing tablets and mixing with apple juice or water is also permissible.
Apple juice or apple puree is excellent because it's of its low pH value. There's a pH of 4.8, and that will dissolve the imatinib perfectly and will also result in a better resorption. Yogurt is also quite good, but of course, the mother has to look that the glass with the apple juice is fully drunken and that all the puree is eaten, not just half of the glass. That would result in a lower dose.
Very practical way to stop there. We might move on to the second case. If there are other questions or comments on this case, we can come back to them later, but let's move on so we make sure we have plenty of time for general discussion. Nirmalya, your second case, please.
Yes, so here we have a boy who was 7 years old at the time of diagnosis, way back in 2009. Diagnosed in chronic phase, imatinib was started, achieved CHR, MMR, and DMR quite soon actually. CMR within 3 months, MMR within 9 months, and DMR was attained at 3 years. He stopped his imatinib way back in 2015. He was told by the physician that you can stop, I mean, if you wish to, but then you'll have to come back to us for every monthly visits. But he defaulted on that. And after 2016, he came back to us 4 years later in September 2020 with fatigue, abdominal distension, weight loss, and a huge spleen and liver. His leukocyte counts at the time of return was 745,000. Sorry. Yes, and if we see the investigations at the time of his return in September 2020, hyperleukocytosis, extreme hyperleukocytosis, 745,000 white cell count, with an absolute neutrophil count of 445,000. However, bone marrow did not show progression of disease. He was still in chronic phase, and fish again showed translocation 922 in 95% of cells. He was started on imatinib. 1 dose of L-asparaginase was given, which is thought to be quite useful for patients with huge spleen and high white cell counts in our setting, and hydroxyurea was also started. He achieved good cytoreduction. However, what we saw was over the next 6 to 8 months, his response was a bit blunted. So in 3 months, he came down from 95 to 40%. However, in about 8 to 9 months from the start of from the time of restart, his fish went up to 78%. At which point his imatinib dose was increased from 400 to 500 and 600 alternately. However, this led to some response, which was also inadequate. And after about a year from the time of restart, he developed cytopenias and intolerance to high dose of imatinib that was started. So his dose was reduced, but his response continued to remain bad, like 90%, 78 to 85%. A bone marrow was repeated at the time when he started to have cytopenias. It showed hypocellular marrow. No excess blasts were seen. Some dyspoetic changes in the megakaryocytes were seen. However, otherwise it was thought to be in chronic phase without anything sinister. And his kinase domain mutation that was done at the time of restart of his imatinib was negative for any resistant mutations. Because of persistent cytopenias and the fact that we were not able to give him proper dose of imatinib, and his fish was also not responding well, he underwent another kinase domain mutation in September 2022. This time it showed an imatinib resistant mutation, E255K mutation, which was a mutation sensitive to dasatinib. So he was switched over to a second generation TKI. Fortunately, by that time, generic dasatinib was available in our country. So he was started on dasatinib 100 milligram once daily based on his body surface area. However, after starting dasatinib at 100, he started dropping his platelets and underwent multiple interruptions due to low platelet counts. His cytogenetic response showed some improvement, but it stood at 33%. The last time it was done in July 2023. Marrow was also done again to see if we were missing anything, but it continued to show dilute marrow with 6% blasts and 0.55% abnormal myeloblasts. And however, cellularity of all three lineages were adequate. So his dasatinib dose was reduced to 50 milligram once daily. And since then he is on that, maintaining his counts okay, but his response assessment has not been done since July, and he is due to come back next month to us. So this makes me ask questions to Dr. Suttorp. So what is your thought on this, on the outcome of these patients who have long interruptions? I mean, what is the eventual outcome that they're going to face, and what is the proportion of patients who develop resistance as a result of interruptions? And do you have any suggestions on improving compliance, particularly in teenagers, as we saw in this patient? And for this particular patient, what do you think would be the next line of action? I mean, if dasatinib doesn't work. Thank you.
Yes, this is a scenario where you have a treatment failure early on, from the 6 months after the relapse occurred. It was clear that there was no good cytogenetic response, but maybe because dasatinib was not available or nilotinib, this boy received imatinib and tolerated that poorly. There are no pediatric data on a cohort who interrupted the treatment and the outcome was. From adults, it was learned that there is a poorer failure-free survival, but the overall survival is not affected. But this may be because second-generation TKI are available and have been administered to these adults. If you compare imatinib with the second-generation TKI, there is this typical cross-intolerance. If you have hematological problems with administration of imatinib, you will see in 30% of cases the same problem with second generations TKI. If available, you could try growth factors. For neutropenia, granulocyte colony stimulating growth factor, erythropoietin to treat the low hemoglobin. And there are some small case series trying L-Trombopac for thrombocytopenia. But of course, in countries with limited resources, it might pose a big problem. So the best is always to switch to second generation TKI as early as possible, and then treat with a low dose if there is cross toxicity, cross intolerance. So in adults, if I remember correctly, the event-free survival of 5 years on adherent patients was in the range of 80% and 60% in the case of non-adherent people. So it is really a challenge, especially in teenagers, to improve the compliance. We see as pediatricians these problems with all chronic diseases. Diabetes type 1 is a typical example. When they are pre-pubertal, they have a wonderful hemoglobin 1C level. When they enter puberty, the hemoglobin 1C level rises all around the globe. And this is the same with other chronic diseases. What can one do? You have to talk to the patients. You can use some, well, the parents may check the tablet box, but teenagers don't like that, to be the parents controlling their treatment. If they have a mobile phone, they can set the alarm clock and take the tablets when the alarm clock is ringing. And a simple note on the mirror when they brush their teeth, that they also take the tablet in the evening. All this might help, but generally it is a big problem to have a good adherence at this teenage age.
Going to the chat, Dr. Marian Ali Khan says, I would advise allogeneic BMT in this case. What do you think, both of you?
Sorry, I didn't get that. Could you repeat the question?
Sorry, Dr. Marian Ali Khan says in the chat, I would advise allogeneic bone marrow transplant in this case. What do you both think?
This is possible, but in the first world countries, I always would try nilotinib first as a bridge to transplant. And there is no, but I don't know whether transplant is a possible option, whether there is a donor. So this has to be balanced in the individual case and with the risk of the transplant and the ponatinib working. There was another question on GCSF. It disappeared on my screen.
Mipsang, would you like to present your question?
Can we take the patients with disease on board? Well, not in blast crisis. All these patients, pediatric patients and adult patients, have a less than 10% probability of survival if they undergo stem cell transplantation in full-blown blast crisis. So achieving hematological response is a minimum. Better, of course, is any kind of cytogenetic response. But also the time has to be considered. The median time interval in our pediatric cohort we analyzed here in Germany was some 8 months from blast crisis to the next blast crisis. So the clear recommendation is to perform transplantation within 6 months after the diagnosis of the first blast crisis. And the next line of action treatment would also be, because he has reached adult age, the new STAMP inhibitor, asciminib. But of course, this is a problem of availability. But this worldwide trial is open, and Novartis is recruiting patients in pediatric, and it has been licensed for this scenario in adults. But of course, this is a very costly and expensive drug.
Right, but in this patient, we have failed to document any such mutations which would not respond to a second generation TKI.
Yeah.
So that is the main concern about thinking of something beyond that second generation TKI. Of course, the cost and all that, but I mean, we have a patient who is again a borderline adult who is on ponatinib through a compassionate access program because we have T315 in that patient.
Yeah, with 351, the only drug is ponatinib or asciminib, and stem cell transplantation in the long run might also be more cost effective, less toxicity for the budget.
Right, but in this patient, we don't have anything yet of that sort.
Yeah, no.
And another quick question for you. So what is the overall outcome of these patients if they don't able to take the whole recommended dose? I mean, for example, because of intolerance, they're always on half dose or 1/4 the dose. So would they still be fine, or we'll have to think of changing?
No sound data on this. There will be another relapse within the next months after a blast crisis, especially after secondary blast crisis, and without transplantation, I'm afraid this is a hopeless situation.
Right. But I mean, as of now, he still remains in chronic phase. I mean, based on the latest bone marrows that we have done.
Yes, but this is after a blast crisis, a chronic phase with MR2 molecular response is a perfect scenario if you have a donor.
Right.
Any last questions or comments on this case? We might ask Nirmalya, would you like to have a last comment there? See if anyone else does want to come forward in the last moment.
No? I do not see
All
any.
good. Professor Suttorp, would you like to make a last comment on the pediatric section?
I think
I
these.
have a question, Dr. Suttorp. Let me finish that. I thought that there is another case that we're going to present, which would have been a shorter one. But anyway, so the WHO 2022 classification defines blast phase in a different way, especially for the lymphoid blast phase. So they have not given a cutoff of the proportion of blasts that you have to have for lymphoid blast phase in CML. So, but can you tell us, I mean, what should be our cutoff? Because, I mean, this keeps on coming over and over again. We have flow cytometry results showing, for example, 0.5% lymphoid blasts, 1% lymphoid blasts. What do you think about this low proportion of lymphoid blasts?
Well, the monitoring is, if it is performed by fax analysis, and if the blasts express a typical pattern, you might well use this. I personally prefer the RT-PCR in the low-level range of 1% or less blasts because it's more sensitive and more predictive. And this also works from peripheral blood, you do not need bone marrow. And then again, in a lymphoid blast crisis, you can excellently treat the initial clinical situation with dexamethasone and vincristine, and you might achieve a hematological response and then add TKI and follow the case for 2 to 3 months until bone marrow transplantation is organized. There is an ongoing debate whether you need a full ALL induction to treat these children. I think if by day 15 there is no perfect hematological response, then you may give half an induction of the ALL protocol and then reassess how that worked. But you can spare a lot of toxicity, especially with a sibling donor present, and you proceed to transplant early.
We are really close to being out of time. Dr. Sokran Singh from Cambodia asked a question I think has been answered earlier. I'll get back to you with the response to that. Dr. Krunlan Shah to everyone, should lymphoid blast crisis received ALL-based induction? Is that enough there for you to respond? Professor Suttorp, Professor Moulik, or Dr. Shah, could you expand on that question a little bit? And then we'll wrap it up for the pediatric section.
Well, as I said before, there's an ongoing debate. What is the best induction in lymphoid blast crisis in pediatric patients? There's a paper by a consensus group which was published in Leukemia early this year. So the interested reader is referred to that to save time.
And I will track down that citation and share it with everyone. That sounds very helpful. Professor Moulik, would you like to have a last comment?
Nothing in particular. Thank you very much, Arlene. And I mean, this was a very useful session. And I mean, more and more pediatricians should now get trained and oriented to managing pediatric CML to help out the children, I mean, in the developing countries, which is very important. Thank you.
Thank you.
Thank you. Thank you very much. And as I said earlier, the pediatric CML treatment in low and middle income countries is an area of interest to the foundation, something we would like to pick up and run with more in the future. Thank you very much.